In this lecture, we're going to review data collection procedures for clinical assessment and how we use measurement scales to record characteristics that are going to play an important role in determining outcomes and demonstrating whether or not treatment is effective. The domains typically measured at baseline or intake to treatment need to be planned with an eye towards evaluating treatment outcomes. So ideally what you want to do is have the same measurement at baseline that you put into your assessment battery when you follow people up at the end of treatment or several months after the end of treatment. But we also need to measure a lot more at the beginning of treatment because those variables could be very influential in predicting which types of patients respond to different types of treatment. So the domains that are typically measured include, obviously, substance use, the quantity and frequency of use, the pattern of use, and if we're talking about drugs, the mode of administration. Another major domain is the diagnostic classification according to criteria found in either ICD or DSM or both. So we want to know that not only whether people are using a substance, but whether they meet criteria for a substance use disorder. And if so, what substances are involved. The criteria can be scaled to produce either a binary classification, they either don't have the diagnosis or they do, or a severity classification where in, for example, DSM-5, we can classify people as having either a mild or moderate or a severe disorder. So the number of symptoms can be important and can produce both a binary or yes or no classification, whether they have the diagnosis, but also a severity estimate. Other areas that need to be measured and monitored at follow-up are consequences related to substance use, whether they're legal, social, health and medical, or personal, whether people are employed or not, and criminal activities. And these are the most important domains that are typically measured both at baseline and at follow-up. There are many other types of variables that are measured because of their predictive value or because they need to be controlled for in statistical analyses. For example, demographic characteristics, age, sex, gender, employment, ethnicity. All of these things are important because we know that the severity and the type of substance use differs according to these variables. Psychological processes, attitudes, expectancies, and motivations. Medical and psychiatric history, and we'll be talking about the types of psychiatric disorders that often interact as comorbidities with substance use disorders. And finally, personality traits. You don't have to measure all of these variables in a particular survey. You can choose the variables that are going to be most relevant when you're designing a study. And the types of variables that have been developed over the years is quite impressive. So we now have good psychometric measures of all of these variables that can be incorporated into a battery depending on the purpose of your survey or your study. Time windows are important, and the time windows need to be compatible between baseline and follow-up. Typically, our assessment procedures ask questions within a time frame. Sometimes it's the past month, sometimes it's the past year, and sometimes it's lifetime. Different scales have different time frames attached to them. The timeline follow-back interview procedure, for example, consists of presenting a patient with a calendar of dates going back from the day of the interview, typically for a month or 2 months and sometimes 3 months. Each day, the patient is asked to remember what they were doing during that week and on that day and what they were drinking. And also, you can map onto it other events like drug use. So the timeline follow-back method allows for some flexibility between baseline and follow-up to the extent that you can extend it back 3 months and then follow somebody up at 3 months after treatment and have them fill in all the days since they left treatment. It gives you a very fine-grained measure of a person's substance use. Not all studies require that degree of detail. And if you're not doing a treatment evaluation study, but merely following people over time as a cohort, you may want to get similar time windows when you interview them, let's say on an annual basis. The main thing is that they're compatible between the two periods. Scales should be repeated at follow-up with the same time windows, and we should also be measuring substance use during treatment so that we can find out if people are relapsing. There are 3 types of measurement that are typically used in clinical research on alcohol and drugs. First are interview methods, and you would have read in the assigned readings that the 3 types of interview methods are structured interviews, semi-structured interviews, and unstructured interviews. Structured interviews mean that somebody is trained to do an intake with a patient and they ask the questions in a prescribed way, and typically the responses are yes, no, whether they had a symptom or not. Also, they might be interviewed about their substance use. Semi-structured interviews are typically conducted by trained clinicians who can probe and explore the patient's answers. It can be a little bit more flexible in order for the clinician to use clinical judgment to determine whether the patient has a symptom or not. And unstructured interviews, which are not typically used in research, except in focus groups, allow a very highly trained clinician to arrive at a diagnosis pretty quickly by just following their experience and their intuition. The second type of measurement that is important in the assessment of substance use disorders in clinical settings is self-report questionnaires. Typically, they consist of either yes-no answers or quantity frequency measures where people have to give the number of days that they used or the number of drinks or the number of marijuana joints that they smoked, or other types of scales like Likert scales, which present statements that patients are asked to agree or disagree with. All of these provide quantitative data that can be used to measure change over the course of treatment. Finally, we have objective indicators that come from samples of urine, saliva, or blood. These are called biomarkers, and typical biomarkers for alcohol include blood alcohol level, liver enzymes, and other measures which are sensitive to recent alcohol consumption. PEth, or PETH, is now providing a quick method of getting a blood drop from a person's finger that can be quickly analyzed to determine approximately how much they've been drinking over the past 2 or 3 weeks. This is quite an accomplishment in terms of being able to determine when people come back on a weekly basis or a monthly basis whether they're they've relapsed and begun to use again, at least for alcohol. For drugs, we have urine screens that provide a quick response. We have saliva tests that provide quick data that can be used to evaluate whether somebody has been using one or more drugs. One thing that we need to measure if we're looking at treatment outcomes, and these need to be measured when people enter treatment to begin with, are key variables that interact with outcomes. So predictors are important. These are variables usually used in regression analyses that predict other variables. And it's sometimes referred to as the independent variable. So we know that outcomes are going to be correlated with the number of patient characteristics, not only demographics, but their past severity. From my experience in studying treatment outcomes over the years, one of the biggest predictors of poor treatment outcome is a person's past treatment history. Just by asking how many times they've been treated in the past, we can come up with a good idea of what their prognosis is going to be when they're beginning a new treatment episode. Another type of variable that we want to measure is called covariates. Covariates are variables that are possibly predictive of the outcome under study. It could be of direct interest, or maybe that we just need to protect ourselves against what is called confounding, or an interacting variable. And covariates can be used to explain things, or they can be used to predict things, or they can be used just to control for variance between groups assigned to different conditions, so you can see the direct relationship between the type of treatment intervention they received and their outcomes. So if the two groups assigned to a therapeutic intervention or a control group differ with regard to age, then you definitely want to use age as a covariate in your analyses by controlling for it to see whether your treatment intervention made a difference. The reason for that is that age could be a confounder. A confounding variable is a factor that may be important in explaining the relationship between an intervention and a treatment outcome. So some programs have very poor outcomes, but they also attract the most disadvantaged clients. Is that because the program is bad, or is it because the program is good for that type of client? But if you're comparing programs that attract very difficult clients with programs that attract patients who are much more socially stable and more likely to succeed in treatment, then you're really not evaluating the treatment at all. You're just evaluating the effect of treatment characteristics. That's why we need to control for confounders. A big issue in selecting variables to measure is whether they're categorical or continuous. Categorical variables usually include a finite number of categories. Sex is a categorical variable. Either you're male or female, and now transgender. So we can categorize people according to sex. Other variables are continuous. For example, weight and age and drinking frequency. These variables are continuously distributed, and for statistical purposes, it's always desirable to have continuously distributed variables. But many variables just boil down to being binary characteristics. Other variables that we want to measure in treatment outcome studies and measure these things at baseline are the quality of care, the therapist characteristics, adherence to therapy guidelines, the therapeutic alliance that develops between a patient and a therapist, and the degree of empathy. All of these things may have an important effect on whether a particular treatment is associated with better outcomes. You can have a very good treatment program or therapeutic intervention, but it may not have the desired effect because of poor quality, or because it wasn't a good therapist, or the therapist didn't adhere to the guidelines, or the therapeutic alliance didn't develop because the patient didn't like the therapist, or vice versa, or there wasn't empathy. So treatment process measures need to be measured if you are interested in that particular type of variable. And it also helps to measure them because, as we saw from the TCU model of treatment, all those things that go on during treatment are at least important to control for, if not to study. We're now going to move on to giving you some examples.